السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. This is a video recording for the physiology lecture on capillary circulation in the cardiovascular block. These are the active learning objectives, the intended learning outcomes, the ILOs for this learning activity, and here we have the recommended learning resources as usual. In physiological terms, the capillary circulation is also known as the microcirculation. The microcirculation is defined as the microscopic divisions of the vascular system which function to bring about the exchange of materials, the exchange of nutrients and oxygen between the blood and the interstitial fluid in the various tissues of the body. It also functions to drain the metabolic waste products from the tissues to the blood, and it also plays a role in temperature regulation in the body. Structurally, the microcirculation or the capillary circulation is composed of the capillary beds which we have in the different tissues of the body. A capillary bed is composed of a series of blood vessels through which adequate exchange of gases, nutrients, and the metabolic byproducts take place. Having known that the main function of the microcirculation is the exchange of nutrients, oxygen, and also the metabolic byproducts between the blood and the various body tissues, what do you think the velocity of the blood through the capillary beds? How much is the blood flow velocity in the capillaries? In biophysics, the blood flow velocity is inversely proportional to the cross-sectional area. The capillaries, this diagram shows the total cross-sectional area of the vascular bed, and in this lower panel of the diagram we have the blood flow velocity in centimeters per second. Although the aorta is the largest artery in the body, but since it is a single blood vessel, it has got a very small total cross-sectional area as compared with the huge total cross-sectional area of the capillaries. The huge total cross-sectional area of the capillaries is because we have very large number of capillaries. So despite the fact that the cross-sectional area of each single capillary is very small if we compare it with the cross-sectional area of the aorta, but since we have large number of capillaries, now when we add up the cross-sectional areas of these capillaries, the summed up total cross-sectional area would be much higher than the cross-sectional area of the aorta. And because of that, the blood flow velocity is minimal in the capillaries, and this is very important so that enough time would be available for the exchange of oxygen, nutrients, and the metabolic byproducts between blood in the capillaries and the interstitial fluid. Now let's describe the parts of the microcirculation, the vascular components of a capillary bed. A capillary bed is composed of a series of blood vessels through which adequate exchange of respiratory gases, nutrients, and metabolic waste products take place. These two figures show the components of a vascular bed, the parts of the microcirculation. The first component of a capillary bed are the arterioles. The arterioles are resistance blood vessels which may resist flow of blood to the capillaries, or they may allow greater blood flow through the capillaries. The arteriolar diameter usually ranges from 5 to 100 microns, from 5 to 100 micrometers. They have a thick, smooth muscle layer and an endothelial cell lining. They have precapillary sphincters. So this is a precapillary sphincter. Here we have another precapillary sphincter. And these precapillary sphincter may shut off flow of blood to the capillaries. Hence, when the precapillary sphincters are open, nutritional blood flow through the capillaries, and when the precapillary sphincters are closed, non-nutritional flow or shunt flow occurs because blood would bypass the capillaries and reach the venules. The second component of a capillary bed are the meta-arterioles. The meta-arterioles, this is a meta-arteriole. The meta-arterioles are intermediate resistance blood vessels which are present in some capillary beds. They arise from the arterioles and give rise to capillaries as shown in this figure. They have a diameter of approximately 10 to 20 micrometers, 10 to 20 microns, and they connect with venules and give capillaries, supply capillaries, or they may connect to venules only. They also have precapillary sphincters. Here we have precapillary sphincters which may shut off flow of the blood through the capillary. The other component of a capillary bed are the AV shunts. An AV shunt is a small blood vessel with direct connection between an arteriole and a venule. An AV shunt allows bypass of capillaries if the precapillary sphincters are closed, and in this case the flow would be 100% non-nutritional because the blood would bypass the capillaries and would flow directly from the arteriole to the venule through the AV shunt. The capillaries are the major components of all capillary beds in the body. The capillaries are blood vessels. They are small blood vessels where the exchange of respiratory gases, nutrients, and metabolic byproducts take place. Structurally, they are small blood vessels with about 0.5 to 1 millimeter length and approximately 0.01 millimeter, or in other words 10 micrometers diameter. They do not have smooth muscle cells in their walls. Hence, the walls of the capillaries are only a single endothelial cell thick, and they permit rapid diffusion of water, solutes, and gases across their walls. The density of the capillaries in the different capillary beds in the body reflects the metabolic activity of the tissue. Hence, high density capillaries are present in skeletal muscles, in the myocardial tissue, in the brain, in the liver, and also in the kidneys. On the other hand, low density capillaries are present in the skin and the cartilage, since the skin and the cartilage have low metabolic activities. Functionally, the capillaries are the main site. They are essentially the sites of the exchange of respiratory gases, nutrients, and metabolic byproducts between blood and the interstitial fluid. The arterial system delivers oxygenated blood and nutrients to more than 1 billion capillaries throughout the body. The total surface area of the capillary beds in the body is approximately 1,000 meters squared. So it is a huge surface area, and this huge surface area of the capillary beds of the body is very essential for the exchange of nutrients, gases, and the metabolic byproducts across the capillary walls. It is important to note that the diameters of the capillaries in the different capillary beds in the body are not uniform. In fact, some capillaries have diameter less than that of a red blood cell. Accordingly, as the red blood cells pass through these capillaries, they undergo temporary deformation. It is important that sufficient blood moves through the capillaries to satisfy the oxygen requirements of the body tissues. Failure to do this results in circulatory failure or shock. Now, let's describe the types of the blood capillaries which we have in the different capillary beds in the body. Structurally, there are three types of capillaries: continuous capillaries, fenestrated capillaries, and sinusoids or sinusoidal capillaries. The continuous capillaries have continuous walls with only narrow clefts or slits between the adjacent endothelial cells, while the fenestrated capillaries, in addition to these slits or clefts between the adjacent endothelial cells, they also have pores or fenestrations. The sinusoidal capillaries, they have very wide intercellular clefts compared to the narrow intercellular clefts which we have in the continuous capillaries. Here we have again figures which show the three types of capillaries: the continuous capillaries with only intercellular clefts between the adjacent endothelial cells, and here we have a fenestrated capillary with also fenestrations or pores in some endothelial cells, in addition to the clefts or the slits between the adjacent endothelial cells. The discontinuous or the sinusoidal capillaries, they have wide intercellular clefts, much wider intercellular clefts as compared to the intercellular clefts which we have in the fenestrated capillaries or the continuous capillaries. In this figure, this is a continuous capillary with very narrow intercellular clefts. Here, this is a fenestrated capillary with fenestrations or pores in some endothelial cells, and this is a discontinuous capillary with much wider intercellular clefts. Now, let's describe these three types of capillaries in more details. Continuous capillaries are the capillaries which are present in most body tissues. For example, these are the capillaries which we have in the capillary beds in skeletal muscles, in the lung, and also in the adipose tissue. Structurally, continuous capillaries have continuous endothelial lining, and the adjacent endothelial cells are closely joined together by tight junction. So this is an endothelial cell, this is another endothelial cell, and this is an intercellular cleft or slit between these two adjacent endothelial cells, and these adjacent endothelial cells are closely joined together by tight junctions. This is not an endothelial cell, this is a pericyte. The continuous capillaries, they have thin intercellular slits or thin intercellular clefts of about 2 to 10 nanometer width, in between the adjacent endothelial cells in order to allow the diffusion and the filtration, the bulk flow of water and the water-soluble ions, including sodium, chloride, and also glucose through the capillary walls. The intercellular clefts or the intercellular slits, these are gaps in the tight junctions which join the endothelial cells, the adjacent endothelial cells together. The tight junctions are continuous in the capillaries of the brain, and they do not allow the passage of water-soluble molecules, and they form part of the blood-brain barrier. Here we have a figure which shows a continuous capillary. So this is an endothelial cell. Here we have another endothelial cell, and the adjacent endothelial cells are joined together by tight junctions. Here we have another endothelial cell, and in between the adjacent endothelial cells we have narrow intercellular clefts or slits, and this is a pericyte. Fenestrated capillaries are found in the kidney glomeruli, in the glomerular capillaries, and in the capillaries which we have in the small intestine and endocrine glands. So this is a fenestrated capillary. This is an endothelial cell, and this is another endothelial cell where we have wide pores which are also known as fenestrations. So some of the endothelial cells in the fenestrated capillaries have wide pores or fenestrations. Thus, fenestrated capillaries are very permeable, and they allow even large substances to pass through their walls, but not plasma proteins. Here we have two figures which show a fenestrated capillary. So this is an endothelial cell in the wall of a fenestrated capillary with pores or fenestrations. Here we have another endothelial cell, but this endothelial cell doesn't have fenestrations, and still in between the adjacent endothelial cells we have intercellular clefts or intercellular slits. So here we have, this is an intercellular cleft between the adjacent endothelial cells. So in the fenestrated capillaries, hence there are intercellular clefts, and also there are pores and fenestrations in some of the endothelial cells. Here we have, this is an intercellular cleft. This is tight junction between two adjacent endothelial cells, and these are the fenestrations, the pores, which we have in some endothelial cells in the fenestrated capillaries. The third type of capillaries are the discontinuous capillaries, which are also known as the sinusoids or the sinusoidal capillaries. In these capillaries, the endothelial cells are widely spaced, so they have much wider intercellular clefts or intercellular slits between the adjacent endothelial cells. They also have large irregular lumens, and this slows blood flow through these sinusoidal capillaries. The sinusoidal capillaries have few tight junctions between the adjacent endothelial cells, hence allowing large molecules, even proteins, to pass through. These discontinuous capillaries or the sinusoidal capillaries are located in the liver, in the spleen, in the bone marrow, lymphoid tissues, and some endocrine glands. Now, having finished with the detailed description of the types of the blood capillaries which we have in the capillary beds, let's very briefly describe the regulation of blood flow in the capillary beds. The arterioles and the precapillary sphincters function as control valves in the capillary beds in the tissues they feed. During the fight or flight response, with sympathetic stimulation, flow to the non-essential organs like the kidneys, the skin is clamped off, is shut off. And this is important in order to increase blood flow through the capillaries in the skeletal muscles. The metabolic waste products act as vasodilators since they relax the precapillary sphincters. Physiologically, vasomotion is the intermittent flow of blood through the capillaries in response to altering metabolic needs. Now, let's discuss the most important topic of this learning activity, which is the mechanisms of capillary exchange. Transport of substances across the capillary wall occurs by three major mechanisms. These are diffusion according to the concentration gradient, filtration according to pressure gradient, and transcytosis, which involves vesicle formation and hence is also known as vesicular transport. We shall now describe these three mechanisms in more details. It is important to note first that capillary permeability is not the same in all tissues, rather it is specialized for different tissues. The liver sinusoids have discontinuous endothelium, hence they have higher permeability, and this allows the exchange of solutes and proteins. On the other hand, blood-brain barrier capillaries have very low permeability due to the tight junctions between the adjacent endothelial cells. The kidneys, the glomerular capillaries, and the intestinal capillaries contain fenestrations. These are the pores, and hence they have increased permeability, but of course less than the permeability of the sinusoids or the discontinuous capillaries. Finally, it is interesting to know that clefts or pores only cover approximately 0.02% of the capillary surface area. Now, let's describe diffusion in more details, then we'll move on to describe transcytosis and filtration. Diffusion is defined as the process of movement of particles between blood in the capillaries and the interstitial fluid across the capillary wall down their concentration gradients. Diffusion can occur across the endothelial cells themselves or through the intercellular clefts between the adjacent endothelial cells or through the pores or fenestrations which are present in the fenestrated capillaries. It is the major process by which most nutritional substances and metabolic waste products cross the capillary membrane. The rate of diffusion of solutes across the capillary wall is determined by a modified fixed law of diffusion, which states that the rate of diffusion J is directly proportional to the concentration gradient. Hence, the rate of diffusion is equivalent to the concentration gradient multiplied by P, which is the permeability coefficient. Cb is the concentration of the solute in the blood, and Ct is the concentration of the solute in the tissue. The permeability coefficient is affected by the lipid solubility and the molecular diameter of the solute. Hence, lipid solubility influences speed of diffusion. Since oxygen and carbon dioxide are highly lipid soluble, so they have high permeability. The molecular diameter also impacts solute diffusion, and the diameter of the solute must be small enough for the clefts and the pores in most tissues. Glucose and sodium chloride have relatively high permeability, but albumin doesn't have. In liver, proteins such as albumin can move through the discontinuous endothelium easily. The concentration gradient also influences permeability, since substances are exchanged from a high concentration to a low concentration. Now let's describe the second transport mechanism across the capillary wall, which is transcytosis, which is also known as vesicular transport. This is an active process by which large molecules can be transported across the capillary membrane. Large molecules like, for example, peptide hormones. Vesicular transport involves the formation of vesicles from the endothelial membrane to surround the required particle, and this process is known as endocytosis. The vesicle separates and migrates across the cell to release its content to the other side, and this is considered as exocytosis. The third major transport mechanism across the capillary wall is filtration. Filtration is defined as the process by which water, you know that plasma is mostly water, 90% of the plasma is water. So it is the process by which plasma or water and the dissolved crystalloids in the plasma, the electrolytes and glucose, can filter across the capillary wall according to pressure gradient. Filtration is determined by Starling's forces, which we will describe in the subsequent slides. Filtration is also known as bulk flow, since the movement of water drags along with it the dissolved substances to which the membrane is permeable. Although the amount of the materials which are exchanged by filtration are small compared to the amount of the materials moved by diffusion, the rate of diffusion is 4,000 times as the rate of filtration reabsorption. However, filtration aids diffusion by keeping the fluid across the capillary membrane in a state of continuous motion, as we will describe in the subsequent slides. So now let's define and describe the filtration forces. Four pressures are involved in fluid exchange in the capillary beds in the body. These are physiologically known as Starling's forces and include the capillary hydrostatic pressure, the plasma colloid osmotic pressure, the interstitial fluid hydrostatic pressure, and the interstitial fluid colloid osmotic pressure. The capillary hydrostatic pressure, PC, is important because it is the pressure which is needed to push substances through the capillary slits and capillary pores. Capillary hydrostatic pressure is equivalent to the lateral pressure. It is equivalent to the pressure exerted by the blood on the capillary wall. An increase in the resistance in the arterioles through the action of the catecholamines norepinephrine and epinephrine on alpha-1 adrenergic receptors in the smooth muscle cells of the precapillary sphincter would lower the capillary hydrostatic pressure, because now less blood would flow through the capillaries and would increase the pressure of the blood before the arterioles. This is not the case in the capillary beds, which have predominantly beta-2 adrenergic receptors in the smooth muscle cells of the precapillary sphincters. These would be dilated or have reduced resistance. And when the arteriolar resistance decreases, more blood flows through the capillaries, elevating the capillary hydrostatic pressure. The capillary hydrostatic pressure varies from tissue to tissue. In the glomerular capillaries, it is about 60 millimeters of mercury. It is high because these capillaries are filtering capillaries. On the other hand, it is only about 8 to 10 millimeters of mercury in the capillaries of the intestine and in the pulmonary capillaries, because these are essentially absorptive capillaries. The capillary hydrostatic pressure varies as blood moves along the capillary, being highest at the arteriolar end of the capillary and lowest at the venular end of the capillary. An increase in the capillary hydrostatic pressure will increase the rate of filtration across the capillary wall, and this might lead to edema, as what happens in cases of right-sided failure, as we will describe in the subsequent slides. The interstitial fluid generally has very low hydrostatic pressure. PIF, this is the interstitial fluid hydrostatic pressure. And this pressure is usually given a value near 0. Hence, things which increase the interstitial fluid hydrostatic pressure, such as the support hose, can reduce edema in the legs, because the interstitial fluid hydrostatic pressure opposes filtration. The oncotic or the osmotic pressure is another important force which influences filtration across the capillary wall. The osmotic or the oncotic pressure in the capillaries is the pressure which is mainly related to the presence of the plasma proteins. These plasma proteins cannot cross the capillary walls and hence exert an oncotic or an osmotic pressure. Albumin contributes about 65% to the osmotic pressure, whereas globulins contribute to only 15%. However, an increase in the solute concentration would also result in an increase in the capillary osmotic pressure. Proteins in the surrounding interstitial fluid contribute to the tissue osmotic pressure, which is much lower than the capillary osmotic pressure. The capillary osmotic pressure, C means capillary, leads to reabsorption of water near the venular end of the capillaries, and thus recovers the blood volume. During the process of filtration and reabsorption, there is generally a loss of approximately 15% of the blood volume, as we will see in the subsequent slides, and this lost blood volume is recovered by the lymphatic system. The capillary hydrostatic pressure is the major force favoring filtration, and it has got a value of approximately 40 millimeters of mercury at the arteriolar end of the capillary, and it decreases as blood moves through the capillary, and now its value is approximately 15 millimeters of mercury at the venular end of the capillary. The other force which favors filtration is the osmotic pressure of the interstitial fluid, which has a value of approximately 3 millimeters of mercury at the arteriolar end of the capillary, and its value doesn't change at the venular end of the capillary. These forces which favor filtration are given a positive sign. The forces which oppose filtration are the osmotic pressure of the plasma, which has a value of approximately 28 millimeters of mercury at the arteriolar end of the capillary, and its value doesn't change at the venous end of the capillary. The other force which opposes filtration is the hydrostatic pressure in the interstitial fluid, and we have mentioned that the value of the interstitial fluid hydrostatic pressure is approximately 0. Hence, the net pressures acting at the arteriolar end of the capillary are 40 plus 3, these are the filtration forces, minus 28, which is the force which opposes filtration. The net result is positive 15, so we have net filtration then at the arteriolar end of the capillary. The net of the pressures which act at the venular end of the capillary are 15 plus 3, these are the filtration forces, minus 28, and this is the force which opposes filtration. Thus, the net pressure at the venular end of the capillary is negative 10 millimeters of mercury, which means that we do not have net filtration at the venular end of the capillary. Rather, we have net reabsorption. This figure also summarizes the forces which influence filtration across the capillary wall. In different books you will have slightly different values for the pressures acting on the capillary wall and influencing filtration. The summary of this diagram is that we have net filtration at the arteriolar end of the capillary, and at the venular end of the capillary we have net reabsorption. Now let's determine and calculate the rate of filtration across the capillary wall. We have determined and calculated the rate of diffusion across the capillary wall using the modified Fick's law of diffusion, and in determining and calculating the rate of diffusion, the rate of fluid movement across the capillary wall, we use Starling's equation for net fluid flow across the capillaries. This equation says that the net rate of filtration is equivalent to the filtration coefficient K multiplied by the filtration forces minus the reabsorption forces. These are the filtration forces, which are the capillary hydrostatic pressure plus the interstitial fluid osmotic pressure, and these are the reabsorption forces, which are the capillary oncotic osmotic pressure plus the hydrostatic pressure in the interstitial fluid. The filtration coefficient or the filtration constant K is determined by blood viscosity, the wall thickness, the surface area of the capillaries, and the permeability of the capillary wall to water, and it is high in the liver and the kidneys capillaries, while it is low in the capillaries in the blood-brain barrier. Thus, we have net filtration at the arteriolar end of the capillary, and we have net reabsorption at the venular end of the capillary. However, normally the amount of the fluid filtered slightly exceeds the amount of the fluid reabsorbed and is eventually returned to the circulation by the lymphatics. Using Starling's equation, we can calculate fluid movement at the arteriolar and the venular ends of the capillary. The net filtration rate at the arteriolar or arterial end of the capillary is approximately 20 milliliters of fluid per minute, and the net reabsorption rate at the venous or venular end of the capillary is 18 milliliters of fluid per minute. Hence, there is net filtration of about 2 milliliters per minute for the entire body. This should be removed by the lymphatics in order to prevent edema. Now let's very briefly describe the clinical significance of capillary filtration. In blood loss, in hemorrhage, because of sympathetic activation, the arterioles undergo vasoconstriction, and this decreases the capillary hydrostatic pressure. Hence, the osmotic pressure of the plasma proteins favors absorption of the interstitial fluid, and this increases the blood volume. In congestive heart failure, blood is built up in the veins and hence rising the venous pressure, and accordingly blood is built up also in the capillaries, and this elevates the capillary hydrostatic pressure, increasing the filtration rate, resulting in edema. In hypoproteinemia, as in cases of starvation or liver diseases, there is a decrease in the plasma protein colloid osmotic pressure. Hence, there is loss of fluid from the capillaries, resulting in edema. We can write edema as edema OE or just edema with E. The Americans write it as ED, and the English, the British, write it as OE. I will write it in both ways, the edema or edema. In inflammation, the gaps between the endothelial cells increase because of the inflammatory mediators. Hence, the filtration constant increases and the movement of proteins into the interstitial fluid increases, and this might result in edema. Now, it is very important that the excess filtration fluid, which doesn't return back by reabsorption, it is important that this is returned back to the circulation via the lymphatics. And here we have a figure which summarizes the circulation of the extracellular fluid. So excess extracellular fluid, excess interstitial fluid returns back to the circulation via the lymphatic vessels. The lymphatic vessels include lymphatic capillaries. These are blind sacs which collect excess interstitial fluid. They are blind sacs because they have a closed end in the tissues. They consist of simple squamous epithelial cells, which are also known as endothelial cells, and these endothelial cells, they overlap to form one-way valves within the lumen of the lymphatic capillaries. The gaps between the adjacent endothelial cells in the lymphatic capillaries are very large and they lack tight junctions. The lymphatic capillaries, they possess filaments which anchor them to the connective tissue. So these are the filaments which anchor them to the connective tissue. With contractions, when these filaments contract, they can pull on the endothelial cells and thus allowing proteins and large particles or even cells to enter the lymph system from the interstitial fluid compartment. So here we have figures which show the lymphatic capillaries. So this is a lymphatic capillary with filaments anchoring them to the connective tissue. And here we have overlapping of the endothelial cells of the lymphatic capillaries forming one-way valves. The lymphatic capillaries join together to form larger lymphatic vessels which are known as lymphatics. These lymphatics, they resemble the veins in structure, but they have thinner walls and less smooth muscle cells and less connective tissue, and on the other hand they have more valves than veins. They connect to lymph nodes at various intervals, and these lymphatics, they join together to form larger lymphatic vessels which are known as the lymphatic trunks. The lymphatic trunks, they carry lymph to even larger lymphatic vessels which are known as the lymphatic ducts. Lymphatic ducts are thus formed by the union of lymphatic trunks, and they empty lymph into large veins, the right and the left subclavian vein, just before they join the superior vena cava. Now let's very briefly describe the lymph circulation. Lymph is the fluid which moves along the lymphatic vessels, along the lymphatic capillaries, and along the lymphatics, along the lymphatic trunks, and along the lymphatic ducts back to the circulatory system. It moves along pressure gradient, and the amount which moves is approximately 2 to 4 liters per day, and this is actually equivalent to the excess fluid which has filtered at the arteriolar ends of the capillaries. Valves in the lymph vessels keep flow moving in one direction, and the mechanisms that might contribute to the generation of a pressure gradient and the movement of the lymph in one direction include the activity of the skeletal muscles, which is physiologically known as the milking effect of the skeletal muscles on the lymphatics, and this is explained by the contraction of the skeletal muscles exerting pressure on the lymphatic vessels, hence moving the lymph forward. The pressure changes during breathing, the activity of the respiratory pump also influences the movement of the lymph. The pulsating of the neighboring elastic arteries also helps the movement of the lymph in only one direction towards the lymphatic ducts to empty lymph into the circulatory system. Contraction of the smooth muscle cells, which are present in the walls of the large lymphatic vessels and in the lymphatic ducts, also help in the movement of the lymph. Now let's very briefly describe the composition of the lymph. What is the lymph composed of? It is mostly water as plasma, and in the water we have proteins with less concentration than what we have in the plasma. We have lipids, cholesterol and phospholipids in the form of lipoproteins, and we have neutral fat triglycerides also in the form of lipoproteins, which are known as chylomicrons. Remember, the digestive products of lipids are absorbed through the lymphatics, which we have in the intestine. We also have electrolytes in the lymph, and the concentration of the electrolytes in the lymph is equivalent to the concentration of the electrolytes in the plasma. We also have cells like lymphocytes of all sizes and of all levels of maturity, and rarely we have monocytes or macrophages in the lymph, and we might even have granulocytes when there is infection. Lastly, let's describe the pathophysiology of edema or oedema. And edema is defined as abnormal increase in the interstitial fluid volume. And we mentioned in details the mechanism of the systemic edema in right-sided failure and the mechanism of pulmonary edema in left-sided failure in the lecture on heart failure. The causes of edema are summarized in this figure. Thus, an increase in the capillary hydrostatic pressure would result in edema. The possible causes of an increase in the capillary hydrostatic pressure include arteriolar dilation, because now with arteriolar dilatation or dilation, more blood passes through the capillaries, elevating the capillary hydrostatic pressure. In heart failure, the hydrostatic pressure in the capillaries elevates and also in prolonged standing. A decrease in the capillary osmotic pressure favors filtration and hence favors the formation of edema, like what happens when there is protein malnutrition and in diseases of the liver, because diseases of the liver would result in decreased synthesis of proteins, including albumin, which contributes approximately to 65% of the plasma colloid osmotic pressure. Also, kidney diseases like nephrotic syndrome would lower the plasma colloid osmotic pressure because of increased loss of proteins in urine. The increase in the interstitial fluid osmotic pressure would also favor filtration, hence increasing the possibility of edema, and this happens when there is release of proteins by damaged tissue. Also, an increase in the filtration constant, like what happens in inflammation, in allergies, and in burns, would result in edema. Hence, the causes of oedema or edema, like what the Americans say, include again increased capillary hydrostatic pressure, which might result from excess retention of salt and water by the kidney, as in cases of renal failure and as in cases when there is excess aldosterone hormone and in cases of heart failure, or when there is increased venous pressure, also as in cases of heart failure, or when there is venous obstruction, as when there is a thrombus, and also during pregnancy, or when there is a tumor compressing over a vein. These would all cause local venous occlusion or local venous compression, resulting in localized edema. Whereas the increased venous pressure in heart failure would result in generalized edema, which is known as anasarca clinically. Failure of the venous pump because of failure of the venous valves would also result in local edema because this would result in varicose veins. Arteriolar dilatation and decreased arteriolar resistance, this would result in more blood flowing through the capillaries, elevating the capillary hydrostatic pressure, like what happens when the vasodilator drugs relax the arterioles, and also with excess body heat. The second important cause of edema is the decreased capillary colloid osmotic pressure, as what happens in cases of decreased protein intake, starvation, and this is what we call clinically nutritional edema. And when there are liver diseases like liver cirrhosis, when there is nephrotic syndrome, or there is loss of proteins from the skin, as what happens in burns. The other important cause of edema is the increased capillary permeability as a result of destruction of the endothelial cells, as in cases of burns, or as in cases of allergic release of histamine, also in infection, because bacterial toxins would increase the gaps between the endothelial cells, and also with vitamin C deficiency. The other important cause of edema is the impaired lymphatic drainage and lymphatic obstruction, like what happens in cases of destruction of the lymphatics as a result of trauma or irradiation, or when the lymph flow is obstructed by cancer cells or by filariasis. Filariasis is a disease which is caused by mosquitoes injecting worms known as the filarial worms into the body, and these worms would block the lymphatics. Hence, the excess fluid which filters at the arteriolar ends of the capillaries will not return back to the circulatory system, and it would accumulate in the interstitial fluid, resulting in the development of edema. And here we have lymphatic filariasis. This is a lymphatic edema in the lower limb because of filariasis. Now the leg of this patient looks like the leg of an elephant, hence this condition is known clinically as elephantiasis. Similarly here, this patient has elephantiasis in his two legs. This is a lymphatic edema in the scrotum. And lastly, as I mentioned earlier, elephantiasis is a disease which is characterized or caused by parasitic worms blocking the lymphatic system and is transmitted by mosquitoes. These are the filarial worms. Finally, let's describe very briefly the role of the microcirculation in temperature regulation. The capillaries in the skin are arranged perpendicular to the surface of the skin. The cutaneous circulation is characterized by low density of the capillaries because of the low metabolic rate of the skin, as we mentioned at the beginning of the lecture. There are other unique features of the cutaneous circulation, which include the presence of a venous plexus in the subcutaneous tissue. This venous plexus is responsible for heat transfer to the skin from the blood. We also have arteriovenous anastomosis, which opens or closes in response to changes in the temperature. Hypothalamic temperature regulatory centers respond to temperature sensors, which are known as thermoreceptors in the skin. Hence, if the core blood or surface body temperature is lower than normal, this results in increased sympathetic outflow to the skin, resulting into closure of the arteriovenous anastomosis, and as a result of that, less blood flows through the venous plexus and the capillaries, with less loss of heat from the body, because now the body tries to conserve heat. However, if the temperature falls below 50 degrees Fahrenheit, then the smooth muscle cells which we have in the cutaneous circulation would not be able to maintain contraction, resulting in an overall dilatation, and this is responsible for the red appearance of the exposed skin on a cold winter day. On the other hand, if the core or surface body temperature is high and the body needs to lose heat from the skin, there would be decreased sympathetic outflow to the skin, resulting in opening of the arteriovenous anastomosis, hence increased blood flow in the venous plexus. This allows for a lot of blood in the venous plexus as well as the capillaries, and hence heat is lost from the body, because if the core or the surface body temperature is high, the body needs to lose heat from the body through the skin. Blood in the venous plexus is used to radiate heat to the skin, and that's the end of this lecture. And here we have the intended learning outcomes, the ILOs of this lecture again, and thank you very much for listening.